Yes, and I'm not surprised because of the outcome, and the reason is that the way the question is asked is, of course, flawed, because who would want to operate a young patient with a biological valve? But we will see in a moment why it is a question and why it is not a fact that all young patients should be operated with mechanical valve prosthesis. So if it comes to aortic valve disease, and if it comes to an operation, you always need to have a consent. It's clear that you need to have a proper discussion with the patients, and you need to address all various kind of issues. One issue is, of course, the kind of valve prosthesis, or maybe that you do not need a valve prosthesis because you can deal with the valve in another way. And the other thing is, we heard access, and be it limited access, be it midline stenotomy, or be it even a TAVI procedure. In the talk here, I focus on the mechanical and biological valves, but I just want to raise one point again, because I personally think that this is highly undervalued. And the fact that not all patients have aortic stenosis, lots of patients have aortic regurgitation. And as you all know, aortic regurgitation is a disease where you can preserve the aortic valve. Not all valves. I don't say that you should valve-preserving operations in patients 75 years of age. I don't say that you should do it in everyone who has a bicuspid valve disease. But I would say there's very good evidence that, valve-preserving strategies in these patients work very well. There's good evidence from Tyron David with good long-term outcomes. There's good evidence from my former mentor, Jochen Schäfers, and that it's even possible to be done in bicuspid valves, although the outcomes in bicuspids are not as good as in tricuspids. But as we have heard early on from Professor Antunes, there are certain patients where actually a result which lasts for the next 10 years is maybe something which is already better than what you can achieve with some prosthesis. So, from my point of view, whenever you can preserve the valve, you should preserve the valve and repair the valve instead of placing a prosthesis, because whatever you look at, mechanical or stented bioprosthesis, and that is actually the only proper comparison we have when it comes to serious trials, mechanical valve prosthesis, stented bioprosthesis. Whichever valves you look at, they have also individual problems, and you know them all. When we look back into the guidelines, and that is what legally binds us to a certain degree, it is very clear that if you are less than 60 years of age, the last 2017 guidelines have a 2A recommendation that you should have a mechanical valve prosthesis implanted. There's also a class 1 indication here that if the patient would like to avoid warfarin, if the patient has a strong desire for a bioprosthesis, that needs to be addressed. There's also, of course, evidence here that there are certain patients, like, for example, young women who are planning families, are maybe more preferable treated with bioprosthesis. But from the guidelines, it's very clear, if you're less than 60 years, aortic valve position, you should have a mechanical valve prosthesis if you do not have any other contraindications or a kind of different kind of desire. What we, on the other hand, see, and this is data until 2008 from the Blue Book, it has gone further now, of course. You saw the data from Germany today morning. The number of biological valve implantations is sharply going up. The number of mechanical valve implantations is continuously going down. And to a certain degree, you do not find any good evidence why that happens from the data on patients we have. But there may be more than only data and outcome of trials. If you look back into history, and this is a trial which was published in 2000, it's a prospective randomized trial on mechanical versus biological valve prosthesis. And what you nicely can see when you look at mortality, up to around 10 years, the mortality is the same. Actually, it should say survival, shouldn't it? But nevertheless, it's the same. And then after that, the biological valve prostheses have a higher mortality than the mechanical valve prosthesis. And this is mainly based on the fact that you have a higher incidence of bioprosthetic structural valve failure, mainly in the patient group of less than 65 years of age, as you can see here. But the risk of the reoperation, the risk of the reoperation treatment at that time, that caused a higher mortality in these patients and the inferior survival. However, there are newer randomized trials. This one here is from 2009, where again, a patient group between 55 to 70 years was looked at, a prospective randomized trial, and at 14 years after surgery, there was no difference in survival between the two groups. There was a significant higher rate of valve failure, obviously, in the bioprosthetic group. There was a higher rate of reoperation, but this did not translate into inferior survival. And on the other hand, it was noted that there was a trend for increased bleeding in the mechanical valve series, but actually only a trend. It was not highly significant. When you look at these comparisons, that it's, of course, difficult to have always a randomized trial. It's very cost-intensive and so on. And therefore, you find, of course, other comparisons as well. Propensity matching is something which is quite popular in that respect. And there's some newer data on propensity match cohorts. This one here is from Switzerland and from Professor Carell's group. And as you can see here, a comparison, 10-year comparison of pericardial valves with mechanical prosthesis in patients younger than 60 years. And what you can see, there's a significant difference after this time between the two groups, with a better survival in the mechanical group. However, if you look at the number of risks in the last years of this trial, here on the right, you can see there's a very small number of patients at risk, and that is, of course, something which makes the interpretation of these investigations difficult. Another propensity-matched trial published in 2014, again, young cohort of patients, mechanical versus stented bioprosthetic. You can see on the left that the incidence of major bleeding events was significantly higher in the mechanical group. The incidence of reoperation was significantly higher in the biological group, not surprising for us. But on the other hand, when you look at mortality, 5 years, 10 years, 15 years, 18 years, there is no significant difference between the two groups of patients. So actually, it didn't translate into inferior survival for biological valve patients. Of course, when you look at these kind of trials, you also need to look at the type of prosthesis implanted, because one biological valve prosthesis may not be as good as the other biological valve prosthesis, and we have heard about that today morning. So the vast majority of patients here were treated on the biological side with the Carpentier-Edwards valve, whereas mechanically the vast majority was treated with St. Jude bileaflet valves at the time. But this trial, again, no difference in survival. However, it is quite important to look at the biological valves, because some have shown in the past that they worked better and some have shown that they worked less good. This year's analysis, quite old, 1995. At that time, there was a strong belief that pericardial valves would do better in terms of freedom from structural valve deterioration and porcine valves. The one pericardial valve which has been always highlighted in that direction is a PERIMOUNT valve. This here is recent data on the 20-year outcome of the PERIMOUNT, for example. And at 20 years in the age group of 60 to 70, you have 50% freedom from structural valve degeneration. Interestingly, below 60 years, you have at 18 years 50% freedom from structural valve degeneration. So not too bad as well. But on the other hand, as I said, even pericardial valves, not one pericardial valve may work as good as the other one. This year data just from 2016 comparison between the mitral flow and the PERIMOUNT valve. And there's quite a significant difference in terms of structural valve degeneration, with the mitral flow being much more suffering from valve degeneration than actually the Carpentier-Edwards valve. But on the other hand, you also have very good performing porcine valves. This year's data from the Hancock II. Hancock II, excellent long-term outcomes. But it is not always the valve itself. It is also sometimes what happens to the valve during an operation. And one of the strongest predictors for valve degeneration in this study on the Hancock II was actually prosthetic patient mismatch. So you may use the same device, but if you implant the device in a way it should not be implanted, or you use a too small device for a certain patient, you may affect long-term outcomes. And that is something which, from my point of view, is highly undervalued. But it is important when you compare this data. You also have, of course, data on biological valves you can use for root replacement. But again, the freestyle stentless valve had very good outcomes when you implant it as a full root. Here, below 60 years of age, you have 70% freedom from explantation for structural valve degeneration. But on the other hand, we all know, and in the UK you may know better than in other places, that if you implant in a subcoronary implantation, you have worse outcomes. Yeah, and a lot of people have been had a problem with that. But on the other hand, that cannot mean that you say stentless valves do not work for patients, because it is not the full story. So it's not only about the valve, mechanical or biological. It's not only about the product. It's also how the device is used during surgery. I always find this graph quite helpful when I discuss valve replacements with patients. And the reason is that it shows for biological and mechanical valves the lifetime risk you have as a patient for reoperation or major bleeding. And when you look, for example, at the 55-year-old patient, where the red dot and the blue dot are in the same place, you have a similar risk for bioprosthesis to need repeat treatment for the bioprosthesis. And the risk is similar to if you have a mechanical valve prosthesis suffering from bleeding complications. And you can, of course, see the older you get, the less of risk of reoperation you have, the younger you get, the higher risk you have. But with bleeding, it's, of course, the other way around. Of course, there are, on the other hand, new devices coming up at the market. The Onyx valve is there for a very, very long time already, but now there is good data there that it may need less of a target INR than other mechanical valves. And here 1.5 to 2.0 INR, of course, plays a big difference in terms of risk of bleeding in the future than higher INR rates. And that is, of course, something which may affect long-term outcomes. On the other hand, you have also biological valve prosthesis with kind of new treatment of the used tissue, not a completely new built prosthesis like all the TAVI valves you see or some of the sutureless valves, but a valve which is built on a platform which has been proven in the past, and only one component is changed, which makes success in the future, of course, more likely. So there are new devices coming as well, which will make the discussion again more difficult. In the end, from my point of view, it comes down to the fact, why do patients decide against bioprosthesis? Or I would say, why in the past they always very often have decided against bioprosthesis. And the reason in the past was usually that they didn't want to have repeat surgery. And that was something accepted by cardiologists, and then in the end, and one knew that that was higher risk if you have repeat surgery, and that you have, for that reason, less of a higher risk of mortality. On the other hand, why do patients do not want to have mechanical prosthesis? Well, they don't like warfarin. They read about warfarin. They see it with their grandma. They don't want to take tablets on a regular basis. So lifestyle consideration, quality of life plays a role as well. And this may have changed in the last 20 years. I would say it has changed because nowadays someone who is 55 or 60 wants to live an active life. People have a different kind of attitude to how they live than they had 20 years ago. And that's maybe one of the reasons why it has changed. And also, valve and valve is something which has been developed. And cardiologists do valve and valves, and they know valve and valve procedures, and they see it as a very positive thing. So actually, their main reason not to think about biological valves in the younger patient, the repeat surgery, has gone. They suddenly have something to offer patients, and therefore they are more open to that idea as well. And I believe that is something which is affecting the discussion there as well. But on the other hand, you have seen already, if you treat patients with failing bioprosthesis, you can do a good job with TAVI, but you need to be very careful that you do not suffer from prosthetic patient mismatch afterwards. And one needs to recognize that you do usually a very good job with surgery, particularly in terms of the hemodynamic improvement. However, it means that surgeons also do certain things. I mean, in our series, we did a significant number of root replacement in the series, significant number of root enlargements in this series to achieve better hemodynamic outcomes than with the TAVI procedures. What, from my point of view, is in addition to the fact to decide on mechanical versus biological valves, important is that at the first time, if you decide that you go for a biological valve prosthesis, that at the first time you implant a large valve so that you do not have prosthetic patient mismatch. You keep distance on the coronary artery so that you actually can facilitate TAVI in the future. And you enlarge the aortic root if it's needed, so that you actually do not get into the position to become inferior to TAVI outcomes. Therefore, I would like to conclude that there's an increasing trend to use bioprosthesis for AVR. Patients deserve appropriate consent for the aortic valve surgery, and I'm not sure if that always is completely provided. While mechanical prostheses result in significantly lower structural valve deterioration and reoperation rates, they increase the risk of major bleeding. Treatment for biological structural valve disease has become safer and should not affect survival compared to patients post-mechanical AVR. Thank you very much for your attention.
Thanks very much indeed, Olaf. We'll just have a few brief words from Professor Antunes, and then we'll open the debate to the floor. We are limited for time because the next session will be starting shortly, but we'll have time for a few questions after this.
Well, there has been a quick change of events. I was asked to prepare, I had prepared a talk about the mechanical valve and then to reduce to a few slides. Now I'll have a couple of brief words, okay? Just to, well, I hope that you all seen in the presentation, nice presentation that Olaf just gave to us, that in every single paper comparing biological to mechanical valves, sorry, the light is, mechanical valves were better, okay? And the whole argument was reduced to the question of reoperation versus quality of life. Now, quality of life is something that is different, the concept is different for every single one of us. Of course, I question this quality of life decreased because you take warfarin. Take warfarin once a day at breakfast, you always take breakfast. You change the dosage once it is stable by about once every 3 months if you need to change it. We now know that the mechanical prostheses that are about there, and I do not believe that the double anti-aggregation will be enough for any mechanical prosthesis, including the ONX. I have some personal experience on that. But, and then you do have an increased rate of bleeding. But we know that these prostheses, the bileaflet prostheses, take the two most used ones, the ONX and the Sunjud valve, require a lower INR, which decreases the rate of bleeding. And there is even another thing that improves the quality of life, even with mechanical prosthesis, is that you now can do your own INR at home, like you do for blood sugar, and adjust your doses if you're properly trained. So depending on what the quality of patients, also you may not be able to train all patients on that. So patient's own specificities are important when you decide. So by all means, all what we saw for patients younger than 60 or at least 50 years, mechanical valves came up better. And even when they did not come, and I noticed one slide that Olaf presented say that the mortality after 10 years was 60% for biological, 51% for mechanical valves, which was not statistically different or did not reach statistical significance. Now, I mean, if it was one of you and you had to choose between 60% mortality and 51% mortality, you would choose 51% mortality if you wanted to be in between, even if the statistics was not different. So, I mean, there has been a trend. You saw in earlier slides that in Germany, virtually there are no mechanical valves being implanted right now. There is no new data that proves that that is the correct way. The same way as you see that 2/3 now of the patients, all patients, receive a TAVI instead of a surgical valve replacement. There is no evidence for the time being for that. So I still say that unless there are specific contraindications, unless, even talking about quality of life, patients that are sporting people and want to do. For the common mortal, under the age of 55, mechanical valve is still the gold standard. And will remain like that for a long time, I believe.
Thank you very much indeed for your brief comments. So we have